Welcome back to the deep dive. Today we're tackling something incredibly complex, the pharmacology of the central nervous system.
That's right. Specifically, we're zeroing in on the neurodegenerative diseases, or NDDs. Think Parkinson's, Alzheimer's, MS, ALS.
Yeah, and when you consider the brain itself, billions of neurons, trillions of connections, that blood-brain barrier, it's no wonder treating these conditions is such a huge challenge.
It really is the ultimate puzzle. These are progressive diseases. Neurons are being lost, specific types of neurons, relentlessly.
So our mission today isn't just to list drugs, we want to get deeper.
Exactly. We want you, the listener, to really master the mechanisms. How do these drugs actually work? How do they manipulate that incredibly delicate balance of neurotransmission inside the brain to get some kind of therapeutic effect?
Because ultimately any CNS drug, whether it's for one of these NDDs or even something like anxiety, it has to interfere with neurotransmission somehow.
That's the core principle. It has to alter a step in that process, and it can happen in different places.
Like before the synapse, presynaptically.
Right, affecting how neurotransmitters are made or stored or released, or even how they're cleaned up afterwards, their termination.
Or it could be after the synapse, postsynaptically, activating receptors or blocking them.
Precisely. But here's the thing. To understand how these drugs work on a system that's breaking down, well, you first have to grasp how the system is supposed to work. The normal baseline.
The foundation of CNS signaling. Okay, let's unpack that. Maybe start by comparing the CNS to something a bit simpler, like the autonomic nervous system, the ANS.
That's a great starting point, because on the surface, they seem similar. You've got neurons, neurotransmitters, receptors, the basic building blocks.
But the CNS is just layers upon layers more complex.
Vastly more complicated. And that complexity is key to why CNS pharmacology is so tricky. Our sources point out, three big differences that really matter for understanding the drugs.
Okay, so if the ANS is like, I don't know, a simple two-lane road.
Then the CNS is like a massive, multi-level city grid with traffic lights and roundabouts everywhere.
Got it. Difference number one, the circuitry itself. Just exponentially more complex pathways in the CNS compared to the peripheral ANS.
Okay, number two.
Sheer numbers. The quantity of synapses, the connections between neurons, it's just orders of magnitude greater in the brain.
Makes sense. And the third difference, you said this one was critical for pharmacology.
It really is. It's about the types of signaling. The ANS mainly uses just two main players, acetylcholine, AT, and norepinephrine. Simple enough.
But the CNS?
The CNS uses a whole orchestra of neurotransmitters. And this is crucial. It has these extensive structured networks of inhibitory neurons are constantly modulating everything, providing checks and balances. The ANS doesn't really have that same kind of dedicated inhibitory network structure.
So it's not just about turning signals on, it's about this constant push and pull, excitation versus inhibition.
Exactly. Think of a single neuron. Its main goal is to decide whether or not to fire an action potential, that all or none signal. But it's never a simple yes or no. It's constantly tallying up incoming signals.
Like a tiny election happening every millisecond.
That's a perfect way to put it. It's a constant battle right at the firing threshold. And most CNS synapses work through receptors that are linked to ion channels.
So when a neurotransmitter binds,
it quickly, transiently, pops open an ion channel that changes the electrical potential across the neuron's membrane, pushing it either towards firing or away from firing.
Okay, let's break that down. First, the push towards firing side. The excitatory pathways, how do they work?
These generate what we call excitatory postsynaptic potentials, or EPSPs. Neurons using transmitters like glutamate or sometimes acetylcholine in the CNS release their signal.
And that signal hits the next neuron.
Right. It binds to receptors on the postsynaptic membrane, and this causes a brief influx, a rushing in of positively charged sodium ions, Na plus S.
Positive ions coming in makes the inside of the cell less negative, moving it closer to that firing threshold. A small nudge.
A weak depolarization, exactly. That's the EPSP. But, and this is absolutely key, one single EPSP is almost never enough to make the neuron fire.
Ah, okay. So you need more.
You need many, many EPSPs arriving close together in space and time. They have to add up or summate. Think of it like thousands of tiny pushes needing to combine to finally tip the balance over the threshold.
Okay, that's the excitatory push. What about the inhibitory pull? The signals trying to stop the neuron from firing.
Those generate inhibitory postsynaptic potentials, or IPSPs. These pathways use neurotransmitters like GABA, that's gamma aminobutyric acid, or glycine.
And their job is to make firing less likely.
Correct. They cause hyperpolarization. They make the inside of the neuron more negative, moving the membrane potential further away from the firing threshold, basically increasing the distance the excitatory signals have to cover.
How do they do that? Different ions involved.
Yes. Typically two main ways. Either they let negatively charged chloride ions, ClF, flow into the cell, or they let positively charged potassium ions, K+, flow out of the cell.
Both of those actions would make the inside more negative, right?
Exactly, making it harder for those EPSPs to summate enough to trigger the action potential. It dampens the neuron's excitability.
So bringing it all together, any single neuron is constantly integrating all these incoming votes. Hundreds, maybe thousands of EPSPs and IPSPs, all hitting different receptors simultaneously.
And the neuron's final decision, fire or don't fire, is the net result, the summation of all that input.
This idea of chemically coded tracks you mentioned, that seems really important for treatment.
It's fundamental because specific neurotransmitters like dopamine or serotonin or GABA tend to be used in specific pathways connecting distinct brain regions. They're not just randomly splashed everywhere.
So drugs can target, say, the dopamine system involved in movement without messing up the serotonin system involved in mood too much.
That's the goal. This localization, this chemical coding, gives us a potential foothold. It allows for selective pharmacological modulation. It's the structural basis for how we even attempt to treat diseases like Parkinson's, which hinges on a very specific neurotransmitter deficit in a specific circuit.
Okay, that sets the stage beautifully. Let's transition now into that first major challenge, Parkinson disease.
Right. Parkinson's. It's a progressive neurological disorder, and everyone knows the classic motor symptoms.
The tremor, often starting in one hand, that pill-rolling tremor at rest.
Yes, and the muscular rigidity, that stiffness. Then there's bradykinesia, which just means slowness of movement. Starting movements, carrying them out smoothly, it all becomes difficult.
And the postural problems, too, that stoop posture and shuffling gait later on.
Exactly. And it predominantly affects older adults, usually over 65.
So what's happening underneath? What's the core biological problem?
It boils down to the progressive death of a very specific group of neurons, the dopaminergic neurons, the ones that produce dopamine.
And where are these neurons located?
They originate deep in the midbrain in a structure called the substantia nigra. Nigra means black. It actually looks darker because of neuromelanin in these cells. This area is part of the brain's extrapyramidal system, which helps regulate movement.
Okay, so neurons in the substantia nigra die off.
And these neurons normally send their axons, their projections, up to another key area for motor control called the corpus striatum, or more specifically, the neostriatum.
So less dopamine gets delivered to the neostriatum.
Precisely. Reduced dopamine action in the neostriatum is the direct cause of the motor symptoms.
Now, you mentioned something interesting earlier about how these specific dopamine neurons work. They're not just firing in response to a command, are they?
No, that's a really key point. They fire tonically. Think of it less like a switch being flicked on and off and more like a constant, steady hum or background tone.
A stabilizing influence.
Exactly. This tonic dopamine release provides a kind of baseline inhibitory influence that helps smooth out motor activity, allowing for coordinated movement. It's not initiating the movement itself, but it's providing the stable foundation for it.
So when that tonic hum disappears because the neurons are dying,
the system loses its stability, the foundation crumbles, and this throws a crucial balance in the neostriatum completely out of whack.
the balance between dopamine and acetylcholine?
Exactly. Dopamine and acetylcholine. They normally exist in a delicate equilibrium within the neostriatum. There's kind of mutual inhibition going on.
How does that work?
Dopamine coming from the substantia nigra normally inhibits certain neurons within the neostriatum. At the same time, other neurons in the neostriatum use GABA to inhibit the substantia nigra. It's a feedback loop.
Okay. But in Parkinson's, the dopamine input weakens or disappears.
Right. So that normal inhibitory brake that dopamine puts on certain neurons in the neostriatum is lifted.
And crucially, some of those neurons in the neostriatum are cholinergic. They use acetylcholine, which is generally excitatory in this context.
Precisely. So without the dopamine holding them back, these cholinergic neurons become relatively overactive. Their excitatory ACS signal isn't being counterbalanced properly anymore.
It's not that there's more ADCA, but its effect is magnified because the opposing dopamine isn't there.
You've got it. This relative cholinergic overactivity is thought to be the trigger for the downstream signaling problems throughout the basal ganglia circuits that manifest as the rigidity, tremor, and bradykinesia.
Okay, so that clarifies the core problem. A loss of dopamine leading to relative acetylcholine dominance in the neostriatum.
which points directly to the treatment strategy. It has to be about restoring that balance.
Two main ways to do that, then.
Essentially, yes. Option 1, find ways to boost the dopamine signal back up in the basal ganglia, replace what's missing.
Option 2, counteract the overactive acetylcholine, block its effects.
Right. Either way, the goal is to reestablish something closer to the normal diacetyl balance.
Now, before we get into the specific drugs that do this, you mentioned something called secondary Parkinsonism. That seems important to distinguish.
Absolutely vital, because you can actually cause Parkinson's-like symptoms with certain medications. It's sometimes called pseudo-Parkinsonism, primarily with drugs that block dopamine receptors. The classic examples are older antipsychotic medications, like the phenothiazines, clopramazine, and haloperidol.
So blocking the receptor has the same functional effect as not having enough dopamine to stimulate it in the first place.
Exactly. It produces the same motor symptoms. This is why, generally speaking, you absolutely want to avoid giving those types of antipsychotics to someone who already has Parkinson's disease. It'll make their motor symptoms dramatically worse.
Understanding that really drives home why the primary goal of Parkinson's therapy is to enhance or mimic dopamine signaling.
It does. We need to keep that dopamine signal as constant and stable as possible in the CNS.
Okay, let's dive into those pharmacological strategies. And just to reiterate a crucial point you made earlier.
These drugs are for symptomatic relief only.
Right. They help manage the symptoms caused by the dopamine-acetylcholine imbalance.
But they do absolutely nothing to stop or slow down the underlying death of the dopaminergic neurons. That neurodegenerative process continues.
A sobering but critical reality check. Okay, the foundation stone of treatment.
Undeniably, it's levodopa, almost always given in combination with the other drug, carbidopa.
Levodopa, LDOPA. Why not just give dopamine directly?
The blood-brain barrier problem again. Dopamine itself is a molecule that just can't cross from the bloodstream into the brain effectively.
But levodopa can.
Yes. Levodopa is the metabolic precursor to dopamine. Think of it as the raw ingredient. It uses a specific active transport system like a ferry to get across the blood-brain barrier into the CNS.
And once it's inside the brain?
The surviving dopaminergic neurons in the substantia nigra still have the enzyme, dopamine decarboxylase, that converts levodopa into dopamine. So you're essentially giving their remaining factories the raw materials they need to boost their dopamine production.
Makes sense. So why is it almost always given with carbidopa? What does carbidopa do?
Carbidopa is levodopa's essential bodyguard outside the brain. Here's the issue. That same enzyme, dopamine decarboxylase, that converts levodopa to dopamine in the brain. It's also present in the peripheral tissues, the gut, the liver, etc.
So if you just took levodopa by itself?
A huge amount of it, maybe up to 90%, would get converted into dopamine outside the brain, in the periphery.
And that peripheral dopamine is bad news.
Very bad news. It causes significant side effects. Nausea and vomiting are extremely common because it stimulates a part of the brainstem called the chemoreceptor trigger zone, which controls vomiting.
Okay, what else?
Cardiovascular problems. Peripheral dopamine can stimulate beta-1 receptors in the heart, leading to tachycardia, fast heart rate, and potentially dangerous arrhythmias like ventricular extrasystoles. It can also cause postural hypotension dizziness when standing up.
So most of the drug wouldn't even reach the brain, and the part that converts outside causes nasty side effects. Not ideal.
Not ideal at all. That's where carbidopa comes in. Carbidopa is an inhibitor of that dopamine decarboxylase enzyme. Crucially, carbidopa itself does not cross the blood-brain barrier.
So it stays in the periphery.
And it blocks the conversion of levodopa to dopamine outside the brain. It protects the levodopa while it's traveling in the bloodstream.
Allowing much more levodopa to actually reach the brain and get transported inside.
Exactly. By adding carbidopa, you could reduce the required dose of levodopa by about 75–80%, maybe 4 or 5-fold.
Wow. So much more effective delivery to the target site.
And a dramatic reduction in those peripheral side effects, the nausea, the vomiting, the cardiac issues. It makes levodopa therapy feasible and much more tolerable.
This combination sounds like a game changer, but you mentioned it works well initially, then problems arise. The wearing off effect.
Yes, this is a major limitation, especially as the disease progresses. Levodopa has a very short half-life, only about 1 to 2 hours.
That's really short.
It is. In the early stages of Parkinson's, the remaining dopamine neurons can still store some dopamine made from levodopa and release it relatively smoothly. They act like a buffer.
Okay, smoothing out the drug level fluctuations.
Right. But as more and more of those neurons die off, That storage capacity is lost. The brain becomes completely dependent on the immediate supply of levodopa from the bloodstream.
So the patient's motor control starts to directly mirror the rise and fall of the drug levels in their plasma.
Precisely. As the plasma level drops between doses, the therapeutic effect wears off, and the Parkinson's symptoms tremor, rigidity, slowness return or worsen before the next dose is due. That's wearing off.
That sounds difficult to manage, but then there's the on-off phenomenon, which sounds even worse.
It often is because it's less predictable. The on-off phenomenon describes these sudden, dramatic swings between good mobility, the on state, when the medication seems to be working well, and periods of severe immobility and worsening symptoms, the off state.
And you said this isn't always tied directly to the plasma drug levels.
Correct. While sometimes related to falling drug levels, these fluctuations can also occur unpredictably. It likely reflects more complex changes happening downstream in the brain, alterations in dopamine receptor sensitivity, changes in other neurotransmitter systems as the disease advances. This usually becomes a significant problem after about 3 to 5 years of levodopa therapy.
Managing this must be incredibly challenging for both patients and clinicians.
It is. Dosing schedules become complex, trying to keep levels as stable as possible.
Yeah.
And there are practical things too, like absorption.
How so?
Levodopa is absorbed rapidly from the small intestine, but its absorption and, importantly, its transport into the brain could be hampered by food, specifically high-protein meals.
Why protein?
Because levodopa uses the same active transport system across the gut wall and the blood-brain barrier as large neutral amino acids, which are the building blocks of protein.
So if you take levodopa with a steak,
the amino acids from the steak compete with levodopa for the transporter ferry. Less levodopa gets absorbed and less gets into the brain. This can significantly worsen off periods or reduce the effectiveness of a dose.
so patients need to take it on an empty stomach.
Ideally, yes. Usually recommended about 30 minutes before meals or maybe a couple of hours after to avoid that competition.
Okay. Let's quickly recap the adverse effects. We covered the peripheral ones, mostly solved by carbidopa, but what about side effects that still occur, or CNS effects?
Well, even with carbidopa, some peripheral effects can persist or emerge, like postural hypotension, mydriasis, or pupil dilation can occur. And there's a rather peculiar but benign side effect where saliva and urine can turn a brownish color.
Brownish. Why?
It's due to the oxidation of the catecholamine metabolites of levodopa into melanin-like pigments. It's harmless, but good for patients to be aware of.
And the CNS effects, are these related to too much dopamine activity?
Often, yes. The most significant dose-limiting CNS side effects are abnormal involuntary movements called dyskinesias.
What do those look like?
They can be coriform, sort of writhing, dance-like movements, or dystonic, involving sustained muscle contractions and twisting. They often affect the face, limbs, or trunk. It reflects dopamine overactivity in parts of the basal ganglia.
So it's a tightrope, walk enough dopamine to control Parkinson's symptoms, but not so much that you cause dyskinesias.
Exactly. And as the disease progresses, that therapeutic window narrows, making it harder and harder to find the right dose. We also see CNS effects like hallucinations, confusion, anxiety, and sometimes vivid dreams or even psychosis, especially in older patients or those with pre-existing cognitive issues.
Wow. Okay, and drug interactions. You mentioned a couple of critical ones.
Absolutely critical for anyone managing these patients. First, pyridoxine, which is vitamin B6.
Vitamin B6, why is that a problem?
Because vitamin B6 increases the activity of that peripheral dopamine decarboxylase enzyme. So even with carbidopa present, taking extra B6 can increase the peripheral breakdown of levodopa, reducing the amount that gets to the brain.
So avoid B6 supplements.
Generally, yes, unless specifically indicated and monitored. The second interaction is a major contraindication, combining levodopa with non-selective monoamine oxidase inhibitors, or MAOIs, drugs like phenelzine, tranylcypromine, used sometimes for depression.
Why is that combination so dangerous?
MAO enzymes normally break down catecholamines like dopamine and the norepinephrine. Non-selective MAOIs block this breakdown everywhere. If you add levodopa, which boosts dopamine production, you get a massive buildup of catecholamines systemically,
Leading to?
a potentially fatal hypertensive crisis, dangerously high blood pressure. So absolutely contraindicated. You need at least a 14-day washout period when switching.
And you also mentioned avoiding most antipsychotics because they block dopamine receptors.
Right, they worsen Parkinson's symptoms. The main exception is if a patient develops severe levodopa-induced psychosis. In that specific situation, clinicians might very cautiously use low doses of certain atypical antipsychotics, like quetiapine or clozapine, which have less impact on the motor pathways. But it's a specialist decision.
Okay, that's a deep dive into levodopa carbidopa. What about other strategies? Inhibiting dopamine breakdown.
Yes, if we can't easily make more dopamine reach the brain, maybe we can make the dopamine that is there last longer. This involves targeting the enzymes that metabolize dopamine within the brain itself.
Like MAO-B inhibitors. You mentioned non-selective MAOIs were bad, but these are different.
Exactly. MAO exists in two main forms, MAOA and MAO-B. MAO-B is the predominant form within the dopaminergic areas of the brain, the striatum. So drugs that selectively inhibit MAO-B can increase dopamine levels specifically in the brain without causing that dangerous peripheral hypertensive crisis associated with non-selective inhibition.
Clever. Which drugs are these?
Selegiline was the first. Rasagiline and sulfonamide are newer options. By blocking MAO-B, they reduce dopamine breakdown, effectively boosting and prolonging the effect of dopamine, whether it's endogenously produced or derived from levodopa.
Does selegiline have any quirks?
It does. At higher doses, it can lose its selectivity for MAO-B and start inhibiting MAOA2, which increases the risk. Also, it's metabolized in the body to L-amphetamine and L-methamphetamine.
Amphetamines, does that cause problems?
It can. While sometimes providing a bit of an alerting effect, it often contributes to insomnia, anxiety, or confusion, especially if taken later in the day. So selegiline is usually dosed in the morning.
And rasagiline?
Rasagiline is considered more potent. It's an irreversible inhibitor. And crucially, it is not metabolized to amphetamine-like substances, which is a significant advantage regarding those side effects like insomnia. Sulfonamide is the most recent, also selective and reversible, often used as an add-on therapy.
Okay, so MAO-B inhibitors help keep dopamine around longer. What about the other breakdown enzyme, COMT? You mentioned COMT inhibitors are particularly relevant when using carbidopa.
Yes, this is a really interesting piece of pharmacology. COMT stands for catechol-methyltransferase. It's another enzyme that can metabolize levodopa.
And I thought the main breakdown pathway was decarboxylation, which carbidopa blocks peripherally.
It is the main pathway. Normally, the COMT pathway is pretty minor for levodopa breakdown. However, when you block the main highway, decarboxylation with carbidopa, the body naturally shunts more levodopa traffic down the side road, the COMT pathway.
Ah, like a detour.
Exactly. So peripherally, more levodopa gets converted by COMT into a metabolite called 3-O-methyl-dopa, or 3-OMD.
And why is 3-OMD a problem? Does it do anything bad?
It doesn't seem to have direct pharmacological effects itself, but it causes a major logistical problem. 3-OMD uses the exact same active transport system that ferry as levodopa to get across the blood-brain barrier.
So it competes with levodopa for the ride into the brain.
Fiercely. High levels of 3-OMD in the blood effectively clog up the transport system, meaning less levodopa can get into the CNS where it's needed. This contributes to dose failures and the wearing off phenomenon.
Okay, so COMT inhibitors are designed to stop the production of this problematic 3-OMD.
Precisely. Drugs like entacapone and tolcapone selectively and reversibly inhibit the COMT enzyme, primarily in the periphery.
So less 3-OMD is made.
Which means less competition for the transporter, allowing more levodopa to cross into the brain per dose. This effectively increases the bioavailability and duration of action of levodopa, helping to manage those motor fluctuations and wearing off.
Are entacapone and tolcapone similar?
They have the same mechanism, but there's a critical safety difference. Tolcapone works both peripherally and centrally, but it carries a significant risk of causing severe, potentially fatal liver damage, fulminating hepatic necrosis.
Wow, okay.
Yeah, so its use is highly restricted, requiring regular liver function monitoring. It's reserved for patients who haven't responded to other therapies.
And entacapone?
Entacapone only works peripherally and does not have that associated liver toxicity risk. For that reason, it has largely replaced tolcapone in clinical practice. It's much safer and is commonly used as an adjunct to levodopa carbidopa.
Got it. So we've covered boosting the precursor levodopa and inhibiting breakdown MAO-B and COMT inhibitors.
Yeah.
What about directly stimulating the dopamine receptors?
Yes, the dopamine receptor agonists. These drugs essentially mimic dopamine, binding to and activating dopamine receptors in the striatum directly.
Bypassing the need for conversion from levodopa.
Exactly. They provide dopaminergic stimulation even when the brain's own dopamine supply is dwindling. Key examples are pramipexole, ropinirole, and rhodogantine. These are the newer non-ergot-derived agonists.
What are the advantages of using these agonists?
Two main ones. First, They generally have a longer duration of action than levodopa, which can lead to smoother, more continuous dopaminergic stimulation and potentially less wearing off.
Okay, and the second?
Clinical studies suggest that starting treatment with an agonist, rather than levodopa, may be associated with a lower risk of developing those troublesome dyskinesias and motor fluctuations early on.
So they might be preferred as initial therapy, especially in younger patients.
Often, yes. The strategy is frequently to start with an agonist to manage symptoms and delay the need to introduce levodopa for as long as possible, thereby postponing the onset of levodopa-related motor complications.
Makes sense. Do they have downsides? Different side effects?
They certainly do. While maybe causing less dyskinesia initially, they can have more issues with things like sedation, sometimes profound sleepiness, or even sudden sleep attacks during daytime activities. Hallucinations and confusion can also be more common than with levodopa, particularly in older patients.
Any other notable side effects?
Yes, impulse control disorders are a well-recognized risk. Things like compulsive gambling, shopping, eating, or hypersexuality. It's thought to be related to dopamine's role in reward pathways. Patients need to be counseled about this possibility.
Are there different ways these agonists are given?
Yes. Pramipexole and Ropinirole are oral tablets. Rotigotine is available as a once-daily transdermal patch, which provides very steady drug delivery over 24 hours, potentially further reducing fluctuations.
And epimorphine, I've heard of that.
Epimorphine is different. It's a potent, short-acting dopamine agonist given by subcutaneous injection. It's not for routine daily use, but rather as a rescue therapy for rapidly treating severe, acute OFF episodes when oral medications aren't working quickly enough.
What about the older ergot-derived agonist bromocriptine? Is it still used?
Much less commonly now.
Yeah.
While it is effective, being derived from ergot alkaloids carries specific risks that the newer non-ergot agonists don't have.
Like what?
Primarily the risk of vasospasm, blood vessel constriction, and, more seriously, fibrosis, a thickening and scarring of tissues, particularly in the heart valves, valvular heart disease, lungs, pulmonary fibrosis, or behind the abdominal cavity, retroperitoneal fibrosis. These risks generally make the non-ergot agonists the preferred choice.
Okay, nearly done with Parkinson's drugs. Just two more categories mentioned, amantadine and antimuscarinics.
Right. Amantadine is interesting. It's actually an old antiviral drug that was serendipitously found to have benefits in Parkinson's.
How does it work? It's not a standard dopamine approach, is it?
It seems to have multiple mechanisms. It may increase dopamine release from remaining neurons. It has some dopamine agonist effects. It blocks dopamine reuptake slightly. It has some anticholinergic activity. And importantly, it also blocks NMDA-type glutamate receptors.
Wow, a bit of everything.
Yeah. It's generally less potent than levodopa, and tolerance can develop, but it can be useful, particularly for reducing levodopa-induced dyskinesias later in the disease. That NMDA antagonism might be key there.
And finally, the antimuscarinic agents, like fenstropine, trihexyphenidyl.
These go back to that core concept of the dopamine-acetylcholine imbalance.
Right. Parkinson's involves relative acetylcholine overactivity.
So these drugs directly block muscarinic acetylcholine receptors in the striatum. They tackle the imbalance from the AC side, reducing the excitatory cholinergic drive.
Are they primary treatments?
No, they're really only used as adjuvant therapy, meaning added on to other drugs, and mainly for controlling tremor and perhaps rigidity. They don't do much for bradykinesia.
And they have side effects limiting their use.
Definitely. They produce the classic antimuscarinics side effects. Dry mouth, blurred vision, constipation, urinary retention, tachycardia, and significantly, especially in older patients, confusion, memory impairment, and hallucinations.
So definitely not ideal for patients who might already have cognitive issues.
Exactly. And they're contraindicated in people with things like glaucoma, they can raise high pressure, or prostatic hyperplasia, can worsen urinary retention. So their role is pretty limited today compared to the dopaminergic strategies.
Okay, that wraps up a very comprehensive look at Parkinson's pharmacology. Let's shift gears completely now to Alzheimer's disease.
Alzheimer's. The most common cause of dementia, tragically affecting millions. The pathology here is quite different from Parkinson's.
What are the key hallmarks in the brain?
Three main features stand out. First, the accumulation of senile plaques, which are extracellular deposits, primarily composed of a protein fragment called beta amyloid.
Okay, plaques outside the neurons.
Second, the formation of neurofibrillary tangles, which are inside neurons, made up of abnormal hyperphosphorylated tau protein.
Tangles inside.
And third, widespread loss of cortical neurons, neurons in the outer layers of the brain responsible for higher cognitive functions. And critically, for current treatments, there's a particular loss of cholinergic neurons.
Neurons that use acetylcholine. Similar to Parkinson's losing dopamine neurons, Alzheimer's has a prominent cholinergic deficit.
Yes, particularly in areas crucial for memory and learning, like the hippocampus and parts of the cortex. This loss of cholinergic transmission is strongly linked to the memory impairments that are characteristic of the disease.
But like with Parkinson's, the current drugs aren't cures, are they?
No, and this is really important to stress. The reality for Alzheimer's treatment right now is purely palliative. The available drugs provide only modest temporary symptom relief, mainly for cognitive function. They do not stop or slow down the underlying neurodegenerative process. The plaques, the tangles, the neuron loss continue.
So what are the strategies then if we can't stop the disease?
Primarily, two approaches based on the known neurochemical changes. First, try to boost the feeling cholinergic system. Second, try to protect neurons from damage caused by glutamate overactivity or excitotoxicity.
Let's start with boosting acetylcholine. How is that done?
Since cholinergic neurons are dying off and producing less acetylcholine, the idea is to make the acetylcholine that is still being released last longer in the synapse. We do this by inhibiting the enzyme that normally breaks it down.
Acetylcholinesterase, or AE, so AD inhibitors.
Exactly. By blocking HE, you increase the concentration and the duration of action of acetylcholine at the synaptic cleft, hopefully improving cholinergic transmission in the circuits that are still partially functional.
Which drugs fall into this category?
The main ones used clinically are donepezil, rivastigmine, and galantamine. They're all reversible inhibitors of AT.
Are they all basically the same, or are there important differences?
There were some key distinctions our expert listeners should definitely grasp. Galantamine, for instance, besides inhibiting ACAK, might also have a secondary mechanism where it enhances the action of acetylcholine at nicotinic receptors, which could potentially offer additional benefit.
Okay. What about rivastigmine? You flagged that one earlier.
Rivastigmine is unique for a couple of really significant reasons. First, clinically, it's the only one of these drugs that is approved not just for Alzheimer's disease, but also for treating the dementia associated with Parkinson's disease.
Ah, so it has a broader indication. That's important.
Very important. Second, and this relates to metabolism, donepezil and galantamine are primarily metabolized by the cytochrome P450 enzyme system in the liver.
The CYP450 system involved in many drug interactions.
Exactly. Rivastigmine, however, is different. It's actually hydrolyzed, broken down by the enzyme it inhibits AC itself and other esterases. It does not significantly involve the CYP450 system.
Why is that such a big deal clinically?
Think about the typical Alzheimer's patient. They're usually elderly and often taking multiple other medications for heart conditions, diabetes, blood pressure, you name it. Polypharmacy is the norm.
Right.
By bypassing the CYP450 system, rivastigmine has a much lower potential for pharmacokinetic drug interactions compared to donepezil or galantamine. This can make it a safer choice in patients on complex medication regimens.
That's a huge practical advantage. Any other unique features of rivastigmine?
It's also available as a transdermal patch worn on the skin. This provides continuous drug delivery, which can lead to more stable plasma levels and might help reduce some of the gastrointestinal side effects that are common with this class.
Which brings us to adverse effects. Since they boost acetylcholine, I assume the side effects are cholinergic.
Predictably so. Nausea, vomiting, diarrhea, loss of appetite, anorexia are very common, especially when starting the medication or increasing the dose. You can also see things like muscle cramps, fatigue, insomnia, and sometimes bradycardia, slow heart rate.
So clinicians really have to weigh the potential for modest cognitive improvement against these often troublesome side effects.
Absolutely. It's a balance, and the benefit is often subtle and may not last indefinitely as the disease progresses.
Okay, that's the cholinergic strategy. What about the second approach, targeting glutamate excitotoxicity?
Right. We know glutamate is the main excitatory neurotransmitter in the brain, essential for learning and memory through processes like long-term potentiation, LTP.
But too much of a good thing can be bad.
Exactly. There's growing evidence that in conditions like Alzheimer's, there might be excessive or prolonged stimulation of glutamate receptors, particularly the NMDA receptor subtype.
NMDA receptors, they let calcium ions into the neuron when activated.
Correct. And while controlled calcium influx is vital for normal signaling, chronic overstimulation of NMDA receptors leads to a massive, sustained influx of calcium, Ca2+.
And too much calcium inside the cell is toxic.
Very toxic. It activates various destructive intracellular pathways, enzymes that break down proteins and membranes, production of free radicals, ultimately leading to neuronal dysfunction and death, often through apoptosis or programmed cell suicide. This whole process is termed excitotoxicity.
So the idea is to block this excessive NMDA receptor activity.
Precisely. And the drug that does this is memantine.
Memantine, an NMDA receptor antagonist.
Yes, it's thought to work by blocking the NMDA receptor channel when it's being pathologically overstimulated, thereby limiting that toxic calcium influx, but potentially still allowing normal transient activation needed for learning and memory.
So it's trying to selectively block the bad activation while sparing the good.
That's the theory. It's indicated for moderate to severe stages of Alzheimer's disease.
How is it used clinically?
Often, it's added to an ACE inhibitor. Since they have completely different mechanisms of action, one boosting ACE, the other blocking glutamate excitotoxicity, the combination might offer additive benefits compared to either drug alone. There's also a theoretical hope that by reducing excitotoxicity, memantine might have some neuroprotective effect, though proving that clinically is difficult.
Does memantine have significant side effects?
Generally, it's considered better tolerated than the ACE inhibitors. Common side effects can include dizziness, headache, confusion, and constipation, but severe adverse effects are less frequent.
Okay. So for Alzheimer's, ACE inhibitors for mild-moderate stages, potentially adding memantine for moderate-severe stages, but neither stops the underlying disease.
That's the current state of play for pharmacotherapy, unfortunately. Research into drugs targeting beta amyloid or tau has been ongoing for decades with many disappointments. So some newer antibody therapies are showing promise in early stages, but that's a whole other deep dive.
Understood. Let's move on to our third neurodegenerative condition. Multiple sclerosis, or MS.
MS is fundamentally different from Parkinson's and Alzheimer's. It's not primarily a disease of neurotransmitter imbalance or protein accumulation.
It's an autoimmune disease, right? The body's own immune system attacks the central nervous system.
Exactly. Specifically, the immune system attacks the myelin sheath, the fatty insulating layer that surrounds nerve axons, like the plastic coating on an electrical wire.
And myelin is crucial for fast nerve signal conduction.
Absolutely. When myelin is damaged or destroyed, demyelination, nerve signal transmission becomes slowed, distorted, or blocked altogether. This leads to the wide variety of neurological symptoms seen in MS, which can affect vision, sensation, strength, coordination, balance, bowel bladder function, depending on where in the CNS the damage occurs.
And it's typically characterized by relapses and remissions, at least initially.
In the most common form, relapsing remitting MS, RRMS, yes, patients experience attacks or relapses of new or worsening symptoms, followed by periods of recovery or remission. However, over time, many patients transition to a secondary progressive phase with more steady worsening, and some have a primary progressive course, PPMS, from the outset.
How is MS treated traditionally?
For acute relapses, the mainstay has always been high-dose corticosteroids, like intravenous methylprednisolone or oral prednisone or dexamethasone.
Why steroids?
They are potent anti-inflammatory and immunosuppressive agents. They help reduce the inflammation in the CNS during an attack, shorten the duration of the relapse, and speed up recovery. But they don't affect the long-term course of the disease.
Okay. And for longer-term management?
Historically, broader immunosuppressants like cyclophosphamide or azathioprine were sometimes used, but their use was limited by toxicity. The real revolution in MS treatment came with the development of the disease-modifying therapies, or DMTs.
DMTs, what's their goal?
Their primary aim is to reduce the frequency and severity of relapses, slow the accumulation of lesions, areas of damage seen on MRI scans, and ultimately delay the progression of long-term disability. They work by modulating or suppressing the underlying autoimmune and inflammatory processes driving the disease.
So they do try to alter the disease course, unlike the drugs for Parkinson's or Alzheimer's.
Correct. This is a major difference in therapeutic philosophy. Let's talk about some of the main classes of DMTs. The first ones developed were injectables.
Like interferon beta.
Yes, interferon beta-1a and beta-1b. Interferons are naturally occurring proteins involved in the immune response. The exact mechanism in MS isn't fully understood, but they have complex immunomodulatory effects that reduce inflammation and likely decrease the migration of inflammatory cells into the CNS.
Are they effective? What are the downsides?
They are moderately effective at reducing relapse rates and MRI activity. Common side effects include flu-like symptoms, fever, chills, muscle aches, especially after injection, and injection site reactions. A more serious potential side effect is depression, and liver function needs monitoring.
What about the other early injectable glatiramer acetate?
Glatiramer is fascinating. It's a synthetic polypeptide, a random mixture of 4 amino acids found in myelin basic protein, one of the components of the myelin sheath.
So it looks like myelin to the immune system.
Kind of. The idea is that it acts like a decoy. It's thought to induce suppressor T cells or shift the immune response away from attacking the body's own myelin. It has a different side effect profile from interferons, mainly injection site reactions, and occasionally a transient post-injection reaction with flushing, chest tightness, and anxiety, but generally no flu-like symptoms or depression risk.
Injectables were the standard for a long time, but now there are oral options, right?
Yes, the advent of oral DMTs was a major step forward in convenience for patients. There are several with different mechanisms.
Such as?
Fingolimod was the first. It's a sphingosine 1-phosphate S1P receptor modulator. It essentially traps certain types of lymphocytes, white blood cells, in the lymph nodes, preventing them from getting into the CNS to cause inflammation and damage.
Traps them in the lymph nodes. Does it have specific risks?
Yes, a key one is bradycardia, a slowing of the heart rate, especially with the very first dose. Patients need to be monitored for several hours after taking the first pill. There are also risks of macular edema, swelling in the eye, liver problems, and increased susceptibility to infections.
Okay. What other oral agents?
Teriflunomide. This drug inhibits an enzyme needed for pyrimidine synthesis, which is crucial for the proliferation of rapidly dividing cells like activated lymphocytes. By reducing the pool of active lymphocytes, it dampens the autoimmune attack.
Any major warnings for teriflunomide?
Yes, it's terigenic, meaning it can cause severe birth defects. So it's absolutely contraindicated in pregnancy and requires careful monitoring and contraceptive measures in women of childbearing potential. It can also cause liver problems and hair thinning.
And dimethyl fumarate.
Dimethyl fumarate has a more complex, not fully elucidated mechanism. It's thought to activate a pathway, NRF2, involved in cellular response to oxidative stress, potentially having both anti-inflammatory and neuroprotective effects. Common side effects include flushing and gastrointestinal issues like abdominal pain, nausea, and diarrhea, particularly when starting treatment.
So several oral options now, offering different mechanisms and risk profiles. What if these aren't effective enough? Are there more powerful treatments?
Yes, for patients with more active disease or who don't respond adequately to the first-line therapies, we move to higher efficacy treatments, which often involve monoclonal antibodies.
Antibodies as drugs, these are usually given by infusion?
Typically, yes. These are engineered antibodies designed to target specific molecules or cells involved in the MS inflammatory process. Examples include natalizumab, alemtuzumab, and ocrelizumab.
What does natalizumab target?
Natalizumab targets a molecule called a 4-integrin on the surface of lymphocytes. This molecule is crucial for allowing these inflammatory cells to stick to the blood vessel walls and cross the blood-brain barrier into the CNS. By blocking it, natalizumab significantly reduces CNS inflammation.
Sounds effective. Any catches?
A major one. Natalizumab carries a significant risk of progressive multifocal leukoencephalopathy, or PML.
PML, what's that?
It's a rare but potentially fatal brain infection caused by the JC virus, a virus that many people carry asymptomatically. Suppressing the immune system's access to the brain with natalizumab can allow this virus to reactivate and cause devastating damage. This risk requires very careful patient selection and monitoring using risk stratification strategies.
Wow. Okay, what about alemtuzumab?
Alemtuzumab targets a protein called CD52, which is present on mature lymphocytes, both T and B cells. Giving alemtuzumab causes profound and long-lasting depletion of these cells. It's highly effective at reducing relapses, but carries risks of serious infusion reactions, increased susceptibility to infections, and paradoxically, secondary autoimmune diseases like thyroid problems or immune thrombocytopenia emerging months or years later as the immune system reconstitutes.
So very high efficacy, but also significant potential risks.
That's the trade-off with many of these powerful agents. And then there's ocrelizumab.
What's special about ocrelizumab?
Ocrelizumab targets CD20, a protein found on the surface of B lymphocytes. It selectively depletes these B cells. Its development was significant for two reasons. First, it highlighted the important role B cells play in MS pathology, which was previously thought to be mainly T-cell driven.
And the second reason?
It was the first DMT ever approved for treating primary progressive MS, PPMS, the form characterized by steady worsening from the start, which previously had no effective treatments. It's also highly effective for relapsing forms. Risks include infusion reactions and increased infection risk.
So the DMT landscape is complex, stratified by efficacy and risk. But are there also drugs just for managing specific MS symptoms?
Absolutely. Symptomatic management is a huge part of MS care. This includes drugs for fatigue, spasticity, pain, bladder dysfunction, etc. But one drug stands out for its unique indication.
What is that?
Dalfampridine. It's an oral medication that blocks potassium channels on nerve fibers.
Potassium channels, how does blocking them help?
In demyelinated axons, potassium channels can become exposed, allowing potassium to leak out excessively during nerve impulse conduction. This leakage can impair the signal. By blocking these channels, dalfampridine is thought to improve action potential conduction in damaged nerves.
And what's its specific approved use?
It's the first and only drug specifically approved to improve walking speed in patients with MS. It doesn't modify the disease itself, but it addresses a very common and disabling functional impairment.
Fascinating. A drug specifically targeting a functional outcome, like walking.
It highlights that focus in MS care, not just stopping the disease process, but also improving function and quality of life.
Okay, let's move to our final disease state for this deep dive, amyotrophic lateral sclerosis, ALS.
ALS, often known as Lou Gehrig's disease. This is a devastating neurodegenerative disease characterized by the progressive loss of motor neurons, the nerve cells that control voluntary muscle movement.
Both upper motor neurons in the brain and lower motor neurons in the brainstem and spinal cord.
Correct. As these motor neurons degenerate and die, the brain loses its ability to initiate and control muscle movement. This leads to progressive muscle weakness, fasciculations, twitching, atrophy, muscle wasting, and eventually paralysis, affecting movement, speech, swallowing, and breathing.
And the prognosis is generally very poor.
Tragically, yes. Average survival is typically only 2 to 5 years from diagnosis, usually due to respiratory failure. Unlike MS, there are currently no cures and only very limited treatment options that modestly slow progression.
What are those options?
There are currently only 2 drugs approved by the FDA, specifically shown to have some impact on the disease course. The first one is riluzole.
Riluzole. We heard that name before. Amantadine and Parkinson's also had some NMDA antagonism. Is riluzole similar?
It does target the glutamate system, yes. Remember excitotoxicity, the idea that excessive glutamate stimulation can kill neurons. That mechanism is also strongly implicated in the death of motor neurons in ALS.
So riluzole blocks glutamate.
It's thought to work primarily by inhibiting glutamate release from presynaptic terminals. It might also block certain postsynaptic glutamate receptors, including NMDA receptors, and it also seems to block voltage-gated sodium channels, which could further reduce neuronal hyperexcitability.
So multiple actions aimed at dampening down that excessive excitatory drive onto motor neurons.
That seems to be the main idea. Clinically, riluzole has been shown to prolong survival, on average, by a few months, and may slightly slow the rate of functional decline, possibly delaying the need for tracheostomy or mechanical ventilation. It's not a cure, but it's the first drug that demonstrated any survival benefit.
Okay. And the second approved drug?
That's edaravone. This has a completely different proposed mechanism.
How does edaravone work?
Edaravone is administered intravenously and acts as a potent antioxidant, a free radical scavenger.
Free radicals. Oxidative stress.
Yes. Oxidative stress damage caused by reactive oxygen species, or free radicals, is another major factor believed to contribute to motor neuron death in ALS. Edaravone is thought to protect neurons by neutralizing these harmful free radicals.
And what's its clinical effect?
Clinical trials show that edaravone can slow the decline in functional rating scores in certain subgroups of ALS patients, suggesting it can modestly slow the progression of the disease. It doesn't necessarily extend survival as clearly as riluzole, but focuses more on preserving function for longer.
So 2 drugs with different mechanisms, reducing excitotoxicity and reducing oxidative stress, both offering modest benefits in slowing down this relentless disease.
That's the current state of ALS pharmacology. Obviously, a huge amount of research is ongoing to find more effective therapies targeting various aspects of the complex pathology.
Absolutely. Okay, we've covered an enormous amount of complex information today, from the fundamental principles of CNS neurotransmission
through the specific imbalances and pathologies in Parkinson's, Alzheimer's, MS, and ALS.
and the diverse pharmacological strategies used to intervene, replacing precursors, blocking breakdown, stimulating or blocking receptors, modulating the immune system, fighting excitotoxicity and oxidative stress.
If we try to synthesize this, 2 major pharmacological themes emerge across these diseases. First, the attempt to rebalance neurotransmitter systems that have gone awry, like restoring the dopamine-acetylcholine ratio in Parkinson's or boosting acetylcholine in Alzheimer's.
And the second theme?
Is the effort, particularly prominent in MS and now emerging in ALS and Alzheimer's research, to target the underlying processes of cell death or dysfunction, whether it's immunomodulation in MS or tackling excitotoxicity and oxidative stress in ALS and potentially Alzheimer's.
So hopefully, for you listening, you now have a much deeper, more structured understanding of how these drugs drugs work at a mechanistic level, why carbidopa is essential with levodopa, why rivastigmine's metabolism matters, how COMT inhibitors help, the rationale behind memantine or riluzole.
Mastering these mechanisms allows you to think critically about the treatments. For instance, it raises an interesting point about excitotoxicity. We saw NMDA antagonism with riluzole in ALS seemingly extending survival, whereas with memantine and Alzheimer's, it provides only modest symptomatic relief.
Why the difference? If the target, NMDA receptor, and mechanism antagonism are related,
It likely underscores how the role and consequences of glutamate excitotoxicity might differ significantly in the specific context of motor neuron death in ALS versus cortical neuron dysfunction in Alzheimer's. The downstream effects and the contribution to the overall disease progression might be quite distinct. It's not just about blocking the receptor, but about what blocking that receptor achieves in the specific pathological environment.
that's a fantastic point for deeper reflection. And one final thought to leave our listeners with, perhaps looking towards the future.
Consider the trajectory we saw in multiple sclerosis. Treatment evolved dramatically from just managing acute relapses to using increasingly powerful DMTs that fundamentally alter the underlying immune attack, aiming to halt disease progression.
A shift from symptom management to disease modification.
Exactly. So the provocative question is, what does this successful shift in MS suggest for Parkinson's and Alzheimer's? If we can develop therapies that profoundly modify the complex immune processes in MS, are we getting closer to finding agents that can truly arrest or even reverse the neurodegenerative processes, the protein aggregation, the specific neuronal loss in Parkinson's and Alzheimer's, moving beyond just managing the neurotransmitter imbalances?
Will we see true disease modification become a reality for these devastating conditions as well?
Finding the answer to that is arguably the biggest challenge and the greatest hope in CNS pharmacology today.